I'm Karina González from Hospital Clínic of Barcelona. First, thank you for the selection of our presentation. I'm going to show a video about robotic pancreatectomy with left nephrectomy that was performed by Dr. Ausani and Dr. Mosquera that just present here. It's a 41-year-old male with a pancreatic adenocarcinoma in the tail that infiltrates the kidney. First, we give him neoadjuvant treatment with gemcitabine and nab-paclitaxel with a partial response. The mass continued infiltrating the left kidney, but the patient was fit for surgery. We decided to go for surgery. Here you have the tumor. First, we do a two steps docking. First, the urological team do the kidney. They mobilize the inferior pole of the kidney, of the left kidney, localize the left kidney artery, renal artery, and cut the artery after hemolog placement. As you see, next to it, there's the vein that it was also dissected in the step. You see that the colon was not mobilized. We will mobilize after that when looking for the pancreas. The gonadal vein will be sectioned with the vessel seal, well, with the synchrocycle in this case, and the ureter will be also sectioned. The kidney was mobilized from the left parietal collicus, and the renal vein was sectioned here. We don't mobilize the superior pole because we will do it in block with the pancreatic resection. We put the patient in the supine position with a little bit of anti-Trendelenburg. 4 robotic ports were used of 8 millimeters and an assistant port of 12 millimeters. We start by dissecting the greater curvature of the stomach to show the pancreas. We always retract the stomach. Here, as the patient had venal splenic infiltration, we had some varices that we section with an endostapler, and always we after that look for the splenic artery. We want to control the splenic artery at the start of the surgery. We always use a tie to help for hemolog placement. It's important in these patients that are elderly to take care about the splenic artery, that it can have some atheroma and have some problems in the artery section. After we mobilize the superior margin of the pancreas, and we go for the plane of the rams. Here you see that we go in the inferior margin of the pancreas. We enter just above the first jejunal limb. So we open tragus ligament. We have the first jejunal limb here. You see that we will cut this is the inferior mesenteric vein that was the drainage was directly to the superior mesenteric vein. We cut it because we needed to take the plane for releasing also the kidney. We pass always with a longer tie the pancreas, and we will dissection the pancreas with an endostapler, including splenic vein. We close the stapler slowly. It is a vascular stapler, and after that we complete the mobilization of the pancreatic stump, mobilizing the inferior border. In this case, the patient had a lot of pancreatitis before, so it was really thick, this tissue in the retroperitoneum, and we use an endostapler. Here we complete the dissection. We release the splenic pole, and we also release the kidney. When all the specimen was detached of the parietal colic, we take it out with a 15 millimeters bag. The patient was well. We always put hemostatic patch in the pancreatic section side. He had no pancreatic fistula. The creatinine peak was 2, and he was discharged with a creatinine of 1.5, and he was discharged on the 6th day. and the definite pathology showed a pancreatic adenocarcinoma that was infiltrating the kidney. It was a T4N1 with negative margins. Thank you very much. And if you have any question?
Thank you very much.
Nephrectomy of the left kidney because your creatinine also risen and the infiltration was not that much. Maybe a urologist could have assisted you in doing a partial nephrectomy of the kidney at that site.
Yeah, well, it could be an option. Really, this is a 81-year-old patient that has no previous renal disease, and we don't want to have the risk of having a pancreatic fistula on the bed of the pancreal nephrectomy, because you should know that pancreatic fistula can increase a lot the risk of bleeding. So this is why we don't do it, but it's an option, and possibly in a younger patient we have think about that.
So I have a question. Did you think about doing a spleen-preserving distal pancreatectomy? The other question is already asked about doing a partial nephrectomy. Could you just have done this spleen-preserving?
Well, by now, I think that there is no a lot of evidence directing that it's safe to preserve the spleen in pancreatic carcinoma. I know that there are some recent publication, and we are in a study with the Netherlands team in assessing that. But in this case, that was a big tumors that have affectation, infiltration of adjacent organs. Male of 81 years old, and with the thrombosis of the artery, splenic artery and the splenic vein, we thought that it was not an option.
Okay, thank you.
Thank you.
So I'll be presenting on the robotic hilar bile duct resection for hilar tumors. I think this is a procedure which requires a good understanding of the anatomy. So we all know that major hepatectomy is often indicated in these patients, but we need to balance the morbidity associated with this procedure along with the radicality. And with a better understanding of the surgical anatomy of the hepatic hilum, now it is feasible to perform this parenchyma preserving surgeries for hilar tumors. As I mentioned, it requires a very good understanding of the anatomy, and I'll be focusing on that aspect. Okay, so this procedure is primarily indicated in patients with bismuth type 1 and 2 hilar cholangiocarcinoma without vascular involvement. That is the most important thing. There should not be any vascular involvement. And in selected patients with low-grade hilar tumors without infiltration beyond the sectoral bile ducts. And so far, I think in the literature, this technique has been performed by the open technique, and we'll be describing the use of robotic approach. So what is hilar bile duct? So that's basically, we all know that Glisonian sheath is thickened at certain portions of the liver, and the portion of the bile duct that is covered by the hilar plate, it's called as the hilar bile duct. So it is that portion of the Glisonian sheath, the hilum, which is thickened, and the bile duct, which is covered by the hilar plate. Okay, the extent of the hilar bile duct is, as you can see, on the right side, it's comparatively, it's shorter than the left side. And if you identify this, the one which is on the bold line. So this portion of the bile duct can be approached without liver splitting, whereas this portion of the bile duct requires liver splitting or a resection. And beyond this, now this is the portion of the hilar bile duct. Beyond that, it requires liver resection because you cannot separate the bile duct from the adjacent structures. So that is another important anatomical point which we should understand. Slide. Okay. So let it play, I think. So this is a hilar bile duct resection without a liver resection. So you can see here. So this is, as you can make out, we are able to reach up to the level of sectoral ducts with just lowering of the hilar plate, and we are appreciating the anterior, the posterior sectoral ducts, and the left hepatic duct. Now this is the hilar bile duct resection without liver resection. And you can see the sectoral anatomy here. And once the infiltration goes up to the level of confluence and you need to go up to the level of segmental ducts, then you need to do the liver resection. So what we traditionally do as a part of hilar bile duct resection is segment 4 resection. So we are marking the segment 4 under ICG guidance. So this is a segment 4B vein draining to the middle hepatic vein, which is divided. So that's a resection of the segment 4. And that gives the better exposure of the hilar bile duct. Now, compared to the previous case, here you can go right up to the segmental ducts. So that's a difference in the exposure which you get without liver resection versus with liver resection. And as you can appreciate here, we have gone right up to the segmental ducts. So you can see here there are multiple segmental ducts, but all of them lie in a single plane. And that allows you to do a single anastomosis irrespective of number of ducts. So as you can see here, we have at least 7 ducts to anastomose, but because they are all lined by the hilar plate, so you can appreciate that you can do a septoplasty and include all these ducts in the single anastomosis. So the better understanding of this anatomy allows us to do the parenchyma preserving surgery, having a good margin without compromising on the oncological outcomes, but also minimizing the morbidity associated with a radical surgery. And that is a concept which we want to highlight from this. And we have done this procedure in 7 patients, primarily in this IPNB. These are the ideal patients. So it's a feasible technique in selected patients, and probably the robotic approach might be the preferred minimal invasive technique because, as you can see here, it requires precise dissection and also very complex anastomosis. Thank you very much.
It's a beautiful presentation and beautiful showing that how the robot can be used for very advanced biliary cancer higher up. The question I have is that you've shown that it's beautifully can be done, but what were the results in these 7 patients? Because the bigger problem you face is the margin clearance and what are the recurrence rate. Cholangiocarcinoma we know is already a little bit advanced cancers with the poor outcomes. So what was the outcomes in these 7 patients?
Yeah, I think that's a very good question. In fact, this is what was in our mind when we thought of doing this procedure. That's why we started off with type 1 and type 2 tumors. And it's imperative that we have the margin assessment intraoperatively by taking the frozen section. So the moment you have any positive margin, then you have to do the liver resection. So that's, and if you have seen here, so we have done in 7 patients. So the first procedure was done 2 years back. And then initially we started off with IP and B. All 3 patients are free of recurrence. We have done in patient with a gallbladder cancer with biliary involvement, this procedure. That patient developed recurrence at 9 months. So that's the only patient who have recurrence among in this subgroup. Now we have started up to type 3 tumors also, where now we are adding a caudate lobectomy along with segment. Because as we all know, the moment the tumor goes beyond the hilum, then we need to add a caudate lobectomy.
Dr. Bhati.
Kalai, excellent presentation. I have two questions. One is whether caudate lobectomy is a routine,
Yes.
because it's very early to get involved the segment 1 branches. And the second question is, I don't understand how a segment 4 resection will improve your margins, because the problem is that the left hepatic duct has a long extrahepatic course, so that's not a problem. The problem is with the right side, and doing a segment 4, you cannot get a better right margin.
So actually what happens is, if you see the first video, so we kind of cave into the liver. Now that is okay for up to the sectoral ducts. But the moment you want to go into the segmental, in fact there is in the open technique, they describe even just doing a liver splitting. That is, you just split the liver along the canted line and then kind of so you will get a much better margin. But then we thought, because the segment 4 resection is primarily to have a better exposure of the hilum. As you rightly mentioned, you can go on the left side, but getting the margin on the right side becomes difficult. Segment 4 resection actually gives a much better exposure even on the right side. And for the caudate lobectomy, yes, this is what we thought. Like, first we wanted to assess the feasibility in type 1 and type 2 tumors. Now we are doing this procedure in type 3 also, adding the caudate lobectomy.
Thank you. One more question. Do you do a lymph node dissection as well?
Yes, yes.
Yeah. Great.
It was there, but I mean, for the shortage of time, I
Yeah, no,
didn't.
that's fine. I understood that. Why you not know, but yeah. Thank you very much.
Thank you.
So this is a 14-year-old girl who had epigastric pain, diagnosed to have a mass in the proximal pancreatic body, underwent an endosono-guided biopsy which showed a solid pseudopapillary epithelial neoplasm. We had a lot of issues in this patient. It's a 14-year-old girl, parents very anxious. Is she going to need an open surgery? They would very much like to have a minimally invasive option. This is a 3D recon, and we can see that the tumor is exactly in the mid-body. Good amount of pancreatic tissue on both the sides, so which side to sacrifice? So Whipple's at age 14 or a distal pancreatic resection at age 14, both quite morbid. And with a pancreatic resection, which is on the distal side, nearly a 40 to 50% risk of diabetes. And also the tumor was benign, we had done a biopsy. We planned for a central pancreatectomy, transect the pancreas proximally as well as distally, and the distal part we plan to reconstruct either through a pancreatojejunostomy or a pancreatogastrostomy. Backup plan was for a distal pancreatectomy. Since it was a benign tumor, we would try to preserve the spleen. As such, this patient fit into the criteria for central resection quite well, because it was a benign tumor, less than 4 centimeters in size, and a good pancreatic remnant of around 5 centimeters. We wouldn't probably attempt it in an elderly patient or somebody who is already diabetic, or in malignant cases where we also need to do a lymph node dissection, because it's not possible with the central pancreatectomy. Okay, so we enter the lesser sac. Gastrocolic omentum is cut. We suspend the stomach with an umbilical tape, and that gives us a good access. This is the tumor in the neck and the proximal body. We start dissecting along the lower pancreatic border. You have to go a little slowly, because most of the time there are a good amount of collaterals over here. And we come across the middle colic vein in the mesentery, and then we just trace it down to the insertion near the into the superior mesenteric vein. And from there we go cranially, start to make the retropancreatic tunnel. And this is one of the critical steps. So small vessels going from the portal vein directly into the pancreas, we just clip and divide. Go all the way as high cranially as we can, and just try to make this tunnel, a so-called tunnel of love, and get to a point where we can confidently say, okay, this is where we are going to have the proximal line of transaction. And so this is the completed tunnel. And then we sort of push the pancreas down and start dissecting at the upper border. We have the station 8 or common hepatic artery lymph nodes. The GDA in this patient was quite close to the tumor, and we had to take it between clips. So we sacrificed the GDA here. On the tumor side, we put a ligature, and then we divided that. And then from the bedside, the bedside assistant actually bring in an atraumatic blunt instrument, a Goldfinger grasper, and put it through the retropancreatic tunnel, and then try to complete the tunnel in that way. And once that is done, then we can actually pass an umbilical tape and sling up the entire pancreas over the portal vein. We used a purple 60 endo-GI stapler and transected. So that was the proximal line of transection. And then we lift up the tumor. This patient had few episodes of subclinical pancreatitis treated conservatively. So we had expected some adhesions below to the splenic artery and the vein, and there were some significant feeding vessels also. So the artery and vein we dissected carefully. Few of the vessels we clipped and divided, and tried to get a good mobilization of the distal stump. Uh, First plan was to do a pancreatico-gastrostomy. That would be more physiological. So we got a good margin, and then we did the distal pancreatic transection. You have to be careful not to use too much of cautery on the distal stump because don't want it to become ischemic. We already mobilized it quite significantly. So once this was done, the tumor is out. Measure the stump. It was very non-dilated pancreatic duct. We put a intracath into the pancreatic duct sort of as a stent, made a posterior gastrotomy. The opening in the stomach is little less than the actual diameter of the pancreatic stump. And the anastomosis we did in a running fashion with 3-0 barbed suture, delayed absorbable, the posterior layer. And here the wristed instruments, they really make a difference. So running fashion, non-interlocking. We have to be careful not to include the duct in any of these sutures. So once the posterior layer is completed, then same thing we repeat on the anterior layer. 3-0 barbed suture. The key here is to have a good mobilization of the stump so that the tension on the anastomosis is not there. And we tie the two threads together. We put a drain in the lesser sac. I also have the habit of reinforcing all these pancreatic stumps with a vascularized falciform pedicle. It's not shown in the video. Patient did well post-operatively. Solid pseudopapillary epithelial neoplasm, no malignancy, all margins clear. So selected patients, we can actually do this. The main advantage is the preservation of the endocrine function. Exocrine is anyway the proximal part is there, but we did a fasting. So as a follow-up, we did a fasting insulin HbA1c for this patient. Everything is normal. Obviously, the long-term data will be awaited. We'll keep on doing this. Thank you very much.
Do you have a habit of using intraoperative ultrasound for delineation? Because, I mean, it's a cross-specialty talk, but in urology, we would have actually done an intraoperative ultrasound to delineate the margins to ensure that we do very close to the tumor.
Yeah, this is definitely possible. This was actually bulging out from the pancreas, but in smaller cases like insulinomas, we do intraoperative ultrasound.
Any other questions? So you left uncinate process in the patient. Did you have any problem with the later on with leaving the uncinate process in there?
So since this was biopsy proven to be a benign lesion, we are comfortable just doing the local resection, not medical.
Very nice video. You're doing it as a functional preserving procedure in a young patient. Pancreaticogastrostomy is known to, the acid will neutralize the alkaline and the exocrine function will be affected. Why not a pancreaticojejunostomy? Was the duct very small, or what was your concern?
The duct was very small. I think there was no concerns about the texture of the pancreas. We could have done a pancreaticojejunostomy. She does have a proximal pancreatic stump which is giving her the bulk of her exocrine secretion. So the tail actually we left more for the endocrine part rather than exocrine. So I was comfortable, and it probably saved a lot of time and two anastomoses also. So I did a gastrostomy.
Very nice video.
Thank you very much.
I'll be presenting my video demonstration of radical antegrade en-bloc pancreaticosplenectomy or RAM. Can you play the video? So the hallmark of RAM is excellent visibility, the early control of vasculature, we insert en-bloc lymphadenectomy, and we can get good peripheral pancreatic margins, and most important, it is modular. You can change your surgery based on the amount of involvement. So there's a 48-year-old lady who came to abdominal pain and a mass on the left side, which is about 7 centimeter mass, which is causing mass effect on the spleen and few lymph nodes, which was not significant. A biopsy shows well-differentiated adenocarcinoma. So we performed this surgery on a Da Vinci platform with one camera in the center, R1 which was the hook on the left side, and 2 ports on the left side and 1 assistant port, which we again popped to use the short form stapler. The first step of the surgery was entering into the left side, where we dissected the gastrocolic ligament with the help of vessel sealer. Again, vessel sealer is a great instrument to have. It ensures that bleeding is less. So then we went to the neck and intrapyloric dissection to identify the gastroepiploid vein, and you can see intrapancreatic dissection was done and the middle colic vein which is entering. Then we did the retrogastric dissection. The idea is to mobilize the pancreas completely and then take a decision about how much of transaction has to be done. So here we proceeded the anterior and posterior and completely mobilized. You can see the Lucas Henley with the gastroepiploid vein entering into the middle colic and into the superior mesenteric vein, the gastroduodenal artery with a large enlarged lymph node, which is a common hepatic node. Once the complete mobilization of neck and head was done, then we continued anteriorly and superiorly over the pancreas and did the complete lymphadenectomy. Then you can see the coronary vein and the left gastric artery there. So we hitched the stomach at 2 places with the help of fledget, and now we proceeded with the main part, that is the posterior dissection of the pancreas. Here the decision had to be taken about what type of ramp we wanted to do. So here you can see the inferior mesenteric vein, which was seen inferiorly and posteriorly. And now we proceed with the retropancreatic dissection, because here we wanted to ensure the margin, we needed R0 margin. So the idea is of ramp, either you can do an anterior or posterior. Traditionally, we used to do just below the pancreas, but here, because the involvement, it was not infiltrating into the kidney and into the adrenal, we did an anterior ramp. So the dissection continued posteriorly when we took the geroid fascia, and we got the entire vascular, the intermesenteric vein and the confluence away, and we clipped individual veins that were going into the tumor. Now the splenic vein was looped at where the intermesenteric vein was entering, and so we took control of the vein first. Then we did the celiac artery trunk exposure, where we already had seen the common hepatic artery. We already identified the left gastric artery. So we identified the splenic artery at its origin. This took some time. Again, because the tumors were very close, we had to go up till the origin, and we looped the splenic artery at the origin. Once this was done, we continued with taking the short gastric vessels, which was going into the splenic artery. Again, at last, we took the splenic artery division at the origin, as you can see. Then we proceeded with clipping the splenic vein. Again, we were happy with the margins that we got, and this also ensured we got good lymphadenectomy to be performed. Once this was done, the entire we had completely dissected the tumor away on all round, and we took the splenopancreatic block fully mobilized, and we decided with about 2 centimeter margin, we transected the at that just distal to the neck of the pancreas. So we used a short form stapler to transect it. Here in this patient, we did not suture the. We were happy with the firing, and we did not suture the stump. Once this was done, we completely with the splenic attachment with the diaphragm was done with the help of vessel sealer. Once this was done, monoblock dissection of the entire tumor with the lymph nodes and the vessels and the spleen was taken, and we put this in the bag, and we recovered it through a small incision. Thank you.